Case 4, which is Tawana. So if you go to the patient list, MCG_DA, TAWA, and you're going to pick here the best diastolic. I don't think it matters, but let's just go together with the best diastolic phase. So right click. And you're going to show the cardiac. So I'll give you a minute to load the images. So just to give you a context for this patient came to the emergency room with chest pain, young person as well with some remote history of drug use. Had a previous chest CT like maybe 6 months before with a calcium at that time was 0. There was no calcification, just a context. So this was like a question came to us, like what's the best test of choice? And the question was like actually patient, like previous CT, there was no calcification. Should even we get a CT? Troponin was mildly elevated with some like increase slowly over time. So just like a context, and this is like an emergency pathway chest pain. So I'm gonna just scroll back and forth. How would you describe this lesion? So I'm coming from the left main, ostial, proximal. Look at that lesion here. And gives a small branch diagonal that comes back. How would you grade this lesion? So I know we talked about the CPR. Again, like there are different ways to assess the degree of stenosis. The way I kind of like I always confirm when you have an axial image and you can go back and find the artery that is free of disease above and below. So for instance, if you come here, although it gave a branch, might be hard to measure the area, but clearly here there's severe stenosis and it's all non-calcified plaque. So this is purely non-calcified plaque causing severe stenosis in the ostial to proximal LAD. Another also, if you look carefully to the RCA, let's walk to the RCA together. So if you look carefully at the PDA at the end of it, there's a clear small narrowing here. You see the cursor here. And this patient did have like also a severe stenosis here, about 75% stenosis in the distal PDA. I think we talked about this in the morning. This is one of the times that actually measuring the diameter is really helpful. So you see how the PDA is really small, it's still about 2. And if you go distal to it, so if I carry my blue cursor, which is the reference point, and I go more distal to that lesion, it comes back, it's still relatively small, about 1.7 to 2 millimeters. So this matters for this patient for planning. So anyway, so I'll go to show you so this is his angiogram, RCA. Again, let's look again at the PDA. We talked about it before. There was some small, so now you can appreciate it's very small, but not worth intervening. But here's the money shot. Look at that proximal LAD. Just right before it gave that large diagonal. So again, severe stenosis of the LAD, non-calcified plaque. Just to kind of put concept here that like the power of 0, I always say, it does not apply to certain patients. So we have to keep that in mind, the calcium score or the absence of calcification on prior cross-sectional CT. So here, so the teaching point here that when you have patients with diabetes, patients with smoking history, patients with FH or like familial hypercholesterolemia, like things that suggest that really strong family history, you have not done the homework for the FH. Be careful of the absence of calcium in the previous calcium score or chest CT to say there's a very low chance of having obstructive or some form of coronary artery disease. This is a perfect example. This patient was a smoker, a young guy, and later on the workup actually came back, ApoB was 200, so very significant, like, like component there. Anyway, any question about this case? So another case, I guess we can try, this is a really interesting case. So let's go to case number 4, which is, case number 3. So you can go through this case. We can go through it together just to point out. So this patient, kind of like different story. This patient has been seen by primary care, then cardiologist for some primary prevention, some subjective symptoms of chest pain and what so came for a cardiac CTA. The bottom line, there was extensive calcification. So this is one of the things we can talk about, how these patients with the coronary artery calcification can be tricky sometimes to image. but more important to risk stratify them. So a lot of calcification. His calcium score was about 914. Let's just quickly look at the LAD. The point is, like, I want to show to you that this was like an alpha scanner, and just like, we did some parameters just to make sure the study will be diagnostic. Again, like when you have a patient with that calcium score, you want to use all the parameters. We can do a good reference point, and we can use the area. So we're getting here about 47% stenosis, and that's what we ended up calling it. So just to point out to you that this patient with a high calcium score, there are some parameters you can do to improve the diagnostic performance. There was an excellent talk this morning, how to balance the KVP, the tube current, how to do the slice thickness with the radiation dose. So this case, actually, I want to just share with you, this is like a patient. We are able to use some of the new technology called the Caristo that they will do something called the pericoronary inflammation and the inflammation score, FAI. So this patient did have a high plaque volume, as you know, and this is, again, different company. There are different companies in the market, but this is one of them, the Caristo. It gives you the plaque, the volume, and what's so by the stages, the DECIDE registry last year showed, like, the above 750, this is extensive stage. The question is how much there is ongoing inflammation around the arteries. So there's a new concept, or this is maybe now 10 years or so, that looks at the proximal segments and try to understand the fats surrounding the arteries of the heart, and understand how much that fat is more actively inflamed, so it becomes more watery, and the Hounsfield unit gets closer to the zero. Again, the zero is water, and on CT it's standardized. So this fat, for instance, here you can see on the color, it's more fatty. It's really less inflamed, less watery. So the whole point of this, and really sometimes raises a question if this is really good enough to rely on it clinically, it argued that this is an extensive stage of plaque, but there is no ongoing inflammation with this patient, since apparently they were already started on statin, ezetimibe, PCSK9 a few months before. So this is a good example to show how, like, I think the future will understand these plaque, just not the plaque volume or calcification, but also the surrounding fats. And this is 6th percentile is really low score, and this is a low score for events in the next 10 years. So I'm going to stop here, and we continue later on. Thank you all.